friends, welcome back to my channel. Today I'm going to talk to you about the different causes of red spots on the face, as well as how to tell the difference between if this is acne or something else altogether. If you are new here to this channel, my name is Chris and I'm a junior doctor currently based in the UK. And on this channel I share my life experiences and journey towards becoming a dermatologist. So today on this channel I'm going to talk about the different causes of facial rash, specifically the red bumps you typically see on the face. So the most common cause of facial rash is acne vulgaris, also known as pimples. Acne is commonly seen in teenagers and young adults. So it arises due to a combination of factors such as the presence of a bacteria called Propionibacterium acnes, excess oil production, as well as a buildup of dead skin cells, also known as hyperkeratinization. So they typically appear as red, angry-looking spots on the face, but can also affect the upper chest and back. The skin may also appear greasy due to excess oil production. You may also see pustules, which are fluid-filled blisters containing a yellowish fluid called pus. Other lesions may include blackheads or whiteheads. This happens when the hair follicle becomes blocked. Blackheads are known as open comedones, which arises because of a pigment called melanin, and this gives the skin its pigment color. Whiteheads are also known as closed comedones, which happens when the hair follicle gets blocked without the presence of melanin. In severe acne, you may also get scarring and post-inflammatory hyperpigmentation. If you would like to know more information on how to manage acne, please check out my other videos as listed here. So the next type of facial rash is rosacea, which typically causes the flushing and redness on the face. Now this is completely different from acne. We don't exactly know what causes this, but it seems to affect more commonly in middle-aged adults as well as fair-skinned individuals. Research has shown that it can be due to an increased sensitivity to bugs and mites such as the Demodex mites. So these mites are part of our normal skin flora, which means they live in the skin and do not cause any problems in the long run. However, in people with rosacea, they tend to occur in greater numbers, which could potentially lead to more inflammation and an increased immune response to these mites. Rosacea is often triggered by certain foods such as alcohol, spicy food, caffeine, and even exercise. It typically presents as flushing and redness on the skin with prominent dilated blood vessels. You may get red bumps or papules and even pustules on the face. If someone is suffering from rosacea for a long time, this can lead to thickening and disfigurement of the nose, also known as rhinophyma. You may also get eye involvement such as redness and gritty eyes. So how do you differentiate rosacea from acne? Well, firstly, the lesions in rosacea typically do not have the blackheads or open comedones that you normally see in acne. At the same time, the distribution of lesions in rosacea is different from that in acne. In rosacea, the lesions typically affect the central face, including the forehead, the nose, the cheeks, as well as the chin. Whereas in acne, the lesions are more widespread in nature. The areas around the eyes and mouth in rosacea are also spared. The history is also very important. The lesions in rosacea come and go in episodes and are often triggered by certain foods and medications, whereas the lesions in acne are more persistent in nature. The treatment is also different for rosacea. In rosacea, you typically go for topical treatments such as Soolantra cream and Rosex's gel for a few months to assess response. If the lesions are more persistent and widespread, you can then consider oral antibiotics and even isotretinoin as you would for acne. Flushing can also be treated with oral tablets such as propranolol and clonidine. So another type of rash is what people term as fungal acne. Now this is strictly not a medical term, and at the start I wasn't quite sure what to make of it. But after doing some research and a bit of digging, it actually stands for Pityrosporum folliculitis or Malassezia folliculitis, and that is a medical term. This is caused by an organism called Malassezia furfur or Pityrosporum ovale, and is an yeast organism that commonly lives on the skin. It usually doesn't cause any problems, but can sometimes present with red, itchy spots on the skin, particularly affecting the upper back, the chest, and rarely affecting the face. It can cause other skin problems such as seborrheic dermatitis, also known as dandruff, and pityriasis versicolor. Fungal acne typically presents as monomorphic, which means the same size and shape, papules or red spots on the skin. This is different from acne where you get different various morphology. Fungal acne is also usually itchy compared to acne lesions, which are typically painful and sore to touch. Fungal acne is also more common in patients who are on long-term antibiotics or who have lowered immune system because of medications or infections. So to diagnose this, we typically take a skin scraping using a sterile blade and examine the sample under the microscope to check for any fungal spores. And here is a list of differences that you can take note of when comparing fungal acne with actual acne. Now, I have to warn you, fungal acne is less common than actual acne, which means chances are if you have red spots on the face, you are more likely to get acne than fungal acne, though in some cases you may get a combination of yeast infection and acne vulgaris. It is important to tell the difference as treatments for fungal acne is different from acne vulgaris. Typically, you start with antifungal products, and in the UK, we normally prescribe 2% ketoconazole shampoo around 2 to 3 times a week. I normally ask my patients to apply a small amount of the shampoo on the affected areas, leave it on for 3 to 5 minutes before washing off with just clear water. In severe cases, we sometimes consider oral antifungal medications such as fluconazole and itraconazole. The last condition I would like to talk about is perioral dermatitis. This is an eruption of painful red, angry-looking papules and pustules around the mouth. The common cause of perioral dermatitis is typically due to excessive topical steroid creams and ointments around the area. Sometimes it can be due to occlusion of the hair follicles due to makeups and cosmetic products. This is usually painful then itchy and typically presents as monomorphic papules and pustules around the mouth. To treat this, we need to stop any topical steroid treatments as well as any occlusive facial products. Patients are warned that they would get an initial withdrawal effect from stopping the steroid creams, and so sometimes we wean the steroid treatments down slowly rather than quickly. We can substitute this with a steroid-sparing agent such as protopic ointments and Ilidil creams. In severe cases, oral antibiotics can be added in to help decrease any skin inflammation. Again, I have summarized the differences that I've talked about in a table format for easy access. Thank you for watching this video. If you enjoyed this, please give this a thumbs up and comment down below so I can continue making useful videos next time. Thank you for watching once again. Goodbye.